Hello, my name is Dr. MYUNG Park. I'm the Chief of Heart Failure, Transplant, and Pulmonary Hypertension at Houston Methodist Hospital. And I'm joined by Dr. Thomas DeSalvo, who's visiting professor with us from Medical University of South Carolina, where he's Chief of Cardiology. Dr. DeSalvo, welcome.
Thank you.
Thank you for joining us.
It's wonderful to be here.
I know that you certainly have had a huge, remarkable imprint in our current understanding of the right ventricle. And we've been struggling with this for decades, actually, we are still in the midst of that struggle in our understanding the basic principles even, and certainly with treatment of patients that we are faced with biventricular dysfunction and advanced heart failure. So I just wanted to get your thoughts. When you look at the amount of incremental improvement in our care of patients with left ventricular heart failure or dysfunction, we have made such amazing strides, you know, from medical therapy to device related, and certainly with, beyond that. What do you think are some of the key reasons why we are so lagging behind in our ability to do the same for the counterpart in the right ventricle?
It's a wonderful question. I think in part we failed to look holistically at the heart as an integrated organ. Although there are two ventricles, the overall function of the heart is the contribution of both, and they're intimate symbiotic partners. They feed off each other's function and dysfunction in ways that we're just coming to understand. From the way they interact every heartbeat to the way in which they likely communicate with molecular and hormonal paracrine signals. They're coupled to different circulations, which informs their different structures and functions. But because of the prevalence of left heart disease, I think there's been appropriate focus on mechanisms of left heart failure. There's simply been less time and attention devoted to the right heart, except in selected instances. Right. As our technologic solutions for left heart disease have advanced, I think all of us are left with a very challenging population of patients who have either unsupported right ventricles or who have lack of integrated cardiac function, where it appears that the right ventricle is the determinant of fate and prognosis and function. So there has to be a renewed interest on aspects of both integrated right and left heart function and potentially selective aspects of right heart function itself. My bias, if you will, not based on a lot of experimental evidence, is that the ventricles are much more similar than they are dissimilar. And that is based on data from both proteomics, genomics. What's unique about the right ventricle is the devolution it undergoes after birth because of its coupling to a low impedance circulation, and its different structure that's determined embryologically. I always think of the heart as fundamentally a structural mechanical organ. In some ways, the molecular events and machinery, which are very highly evolutionary conserved, are secondary to what's ultimately a mechanical contractile efficiency problem coupled to circulatory conditions.
So if you look at it in that aspect, certainly the two ventricles sharing more cellular and other components than being different. Why is it that when you have somebody who has more predominant, say, RV dysfunction than LV, but certainly do share some component of both, and you treat with the neurohormonal modulators that we have, which certainly are beneficial in the LV dysfunction, that their effect on the RV is not as great?
Yeah, that's a very insightful comment that begs the question of why the RV doesn't appear to respond as beneficially as the left ventricle does to neurohormonal antagonism, for example, or other electromechanical interventions like cardiac resynchronization therapy. There may be different ways in which actually the ventricles, despite their commonalities in so many ways, are engineered to respond to load. And that research is in its nascent stage. We don't know, for example, if there's differential ability of the right and left ventricles to respond with the same degree of hypertrophy, fibrosis, structural, and even myocyte remodeling to account for the same relative conditions of load. I wouldn't be surprised if there are differences that are not so much due to the intrinsic sarcomeric components and protein composition, but that are actually linked to other aspects, either partially determined by the epigenome, which is likely reset. If one follows the very basic literature, taking isolated heart cells out of the heart and plating them in different conditions, they become very different phenotypically and genetically. And all that information, I think, is fed back to the genome to allow a different cassette of expression to go forward. That's my bias anyway. No one's really done those experiments yet in the right ventricle and done them carefully and parsed through what are the pathways for potential adaptation. There's more known about the left ventricle. To date, our understanding of the left ventricle is that it's neurohormonally overstimulated and that antagonism of those systems is beneficial, almost independent of etiology.
Exactly.
That same benefit doesn't appear to translate to the right ventricle. So is the right ventricle intrinsically less responsive to beta agonism, angiotensin signaling, aldosterone signaling? Is it less responsive to the antifibrotic effects of aldosterone antagonism, for example? No one really knows the answers to those questions. And I think those have to be resolved before we have a different menu of options. What we know now is that the right heart is exquisitely programmed to sense prevailing change in load, and it adapts its structure and function accordingly. And that function in turn is critically dependent on the left heart. So it'll be complex because of this true interdependency.
Exactly, right.
To tease out what's truly unique about the RV and what's shared between
the
ventricles. We don't really understand how the ventricles signal to each other, but
and also the important, the role of the septum. I think that is another area.
It is, and
Yes.
teleologically, the body sets certain boundary conditions almost to mechanical efficiency based on size, shape, geometric three-dimensional arrangement of tissue, the way stress and strain are developed. Ultimately, what the intact heart circulation wants is appropriate stroke volume at low pressures to feed the body's needs over the range of pressure volume conditions. Maybe there are multiple pathways to get there. And each person, if you take a step back, if evolution induces random variation by design to allow for maximum adaptility to environmental conditions, you wouldn't want every heart to respond in the same way. We make a lot of simplistic assumptions that a human heart is comparable to a human heart is comparable to a human heart. In some ways, sure. In other ways, probably not. If you were the great designer, you wouldn't want a stereotypic response every time the pulmonary arterial afterload is augmented. You'd want a range of responses, and there may be more built-in range responsiveness in the right heart than is present in the left heart.
And in thinking in that vein, so if you have this organ that is between the left ventricle and the pulmonary circulation, so if the RV becomes dysfunctional, again, thinking simplistically, if you modulate the pressure load, decreasing that, and try to optimize the filling pressures and the environment thereof, I mean, certainly, why can't that simple approach be something that can be utilized? And we know, because we tried it, it doesn't.
Yeah.
So, I mean, there's got to be something inherent that we're missing.
No, I agree.
That
I agree completely.
Drives the progression of the disease and that sort of selects the mechanism of who responds and who doesn't. Which approach.
If you think through it in a different way, so the signals that return to the left heart that are critical to promote adverse remodeling, right, or hormonal signals, neurohormonal signals, critically dependent upon patterns and flows across the arterial systemic circulation. The right heart doesn't flow blood across the systemic arterial circulation, so why would it be responsive necessarily to those same systemic arterial conditions? Why would it not be fed back information, however received, from the pulmonary circulation? Because that's what it's coupled to.
Yes.
And it's coupled to that to maintain, again, a normal amount of flow to fill the left heart. That's all the right heart has to do at an acceptable systemic venous pressure.
Yes.
If anything, it would respond to systemic venous pressure elevation, There's probably a hepato-right ventricular axis that no one's explored. There's probably a renal right ventricular axis that no one's explored that might not be the same, that's dependent on the pattern of systemic arterial flow. And there probably is some feedback loop to the pulmonary circulation back to the right ventricle. And those are the things that need much more careful explanation, rather than signals that may be directed more to alter the contractile state of the left ventricle. So, you know, all the things that are feeding back to the left ventricle are attempts, probably teleologically as we evolve, to respond to hypovolemia, hemorrhage, volume loading, to augment cardiac output. That's not the right signal to come back to the right heart, because its contractile responsiveness probably has boundaries, right? It's the signal to modulate pulmonary vascular resistance. So there's probably more dynamic interplay between the right ventricle and the pulmonary circulation that we understand. Now, whether that's neurally mediated, which no one has really looked much at, or whether it's hormonal or paracrine mediated, or whether there's information imbued in the phasic flow that's sensed by the endothelium that somehow signals back to the heart. I think we have to start thinking much more agnostically, in a blue sky physiologic approach, to think, how could these things be talking? You know, our bias is to look at isolated molecular pathways that have a fairly large bang for one's buck. It's been clearly shown in left heart failure, but what's next? It's not at all clear what's next, because the pathways are not yet clear, and they're probably different than a receptor and an agonist and a, you know, intracellular signal transduction cascade. So they're integrated loops of physiology that we don't have information about yet.
And it's the involvement of the right ventricle with, as you said, sort of the whole outside the realm of just the cardiovascular system. And you mentioned absolutely the cardiorenal, the cardiohepatic, and even taking the lung parenchyma, even itself. I mean, it has a direct connection, and how do the function and dysfunction of the other organs affect the progression or the workings of the RV?
Heart failure, whether right, left, both, is a systemic condition. If the blood flow pattern and supply and venous and arterial pressures are not normalized, it's a pathologic, non-homeostatic state, and there are lots of feedback loops. An example is the biomarker field for left heart failure. Many of those biomarkers are not secreted in the heart. In fact, many are not found in the heart. When we did a small study looking at right ventricular expressed biomarkers, it's a very different menu of molecular candidates than is explained by what you find in plasma or serum. Because what's happening in tissue is influenced by and reflecting perhaps, but it's not necessarily determined by. So those connections between the intact organism have to be made. We tend as cardiologists to look at the heart and circulation system as a standalone entity. Nothing in our body is standalone. It's the assemblage of things, how they're interacting and communicating, which we don't understand very well. Whenever we've taken a deep dive into something that's had major impact, like beta blockers, ACE inhibitors, aldosterone antagonists, the more they're studied, the more you find pleiotropic, off-target effects that determine outcomes, right? ACE inhibitors are powerful because they do things beyond the heart to stabilize cardiovascular homeostasis. Beta blockers, the same. Aldosterone, the same. What we need is the next candidate. It may have indirect effects on the heart. We don't look for those things.
Well, I think we were hoping that the pulmonary vasodilator were those next candidates, but I think we're finding out that may not be I mean, what we thought it was.
You're approaching a really important insight, which is that mechanical unloading alone is necessary but not sufficient to prevent disease progression and ultimately inform clinical outcomes for our patients. So that's been learned in spades by all the failed therapies for left heart failure that have either had trial stoppage early or never come to FDA approval.
So if you could impart future direction as to where you think for the upcoming researchers that have interest in this field, and certainly I hope there are a lot for all of our sakes, where would you target maybe one or two areas that you think really is enriched, we should look there? Where would you go?
I would Well, first of all, my recommendation would be to take the blinders off completely. Ignore a reductionistic approach with one pathway, one molecule, one signaling system at a time. Look at the assemblage and the integrated biology. We don't really have the tools for that yet. I'm always reminded, and this is a little tangential, but not all great ideas in science were derived by data and mathematical analysis.
So true.
Einstein thought that there had to be a relationship, between the speed of light, mass, and energy.
Yes.
He came to it almost intuitively. He said, no, these things have to be related. And he worked back to find the mathematics that worked well enough. It's not perfect, and it's not exactly, but it's a pretty good next level description of what's happening. In biology, we have to do the same thing. Someone has to take a huge step back and say, the organism is what determines the fate of everything. Yeah, I mean, the right ventricle is coupled to the lungs and veins, and there's the left heart. But what else is determining this? Until we free ourselves from the limitations of our training and our backgrounds, which often we've sacrificed years of effort to do,
right.
We're never going to get to that next kind of breakthrough in concept that will be important in our field, because many of us feel that we're conceptually stuck.
I think that's where we are.
What's the next big idea to test? And there'll be lots of failures of big ideas, but we have to let things fail and think broadly, and again, relieve ourselves from our preconceptions of how biology should or shouldn't work. It may just be an intuition based on studying other systems or other organs. So if it were me, I would focus time and attention on how the pathways that are invoked during embryologic development and during involution of the right heart after birth are or aren't accessible during acquired diseases in humans. It's going to be looking at how the combination of inside-out and outside-in signaling is combining to allow tissue to respond. It'll be a combination of epigenetic marking, some of which may be a point of no return, like many have talked about the left heart. The heart appears to have crossed a Rubicon at a certain point.
Yes.
Whether that's something as simplistic as just not having enough functional cells and massive sarcomeres to keep the work undergoing, or whether it's something else with how those cells are arrayed in three-dimensional space, I think it will ultimately convene on a very structural, mechanically sound argument. And no one's done that kind of work in the RV yet, to study the structure and how it differs from a healthy normal RV, and to backtrack it to the epigenetic inside-out signaling and the outside-in signaling from a non-biased approach to all the things that are entering a living functional cell to tell it what to do next.
Well, it seems like there's a lot more work to be done. And it's, it's such an amazing field.
Yeah, it is. It's a wonderful field.
It is. It really is. And I hope that the future practitioners and researchers that are coming really do look to make sure, to help us get there so that we can indeed treat the left and the right and the whole cardiovascular system as a unit and not as a discrete entity.
It's a wonderful paradox of our field that with the therapeutic successes we've had, we've created new problems. We've created a new problem in some ways of right heart failure. We do that in patients with LVAD support. We do that in patients with pulmonary hypertension who live longer than they did before. We do that in part with our successful therapies in left heart failure. So it suggests completely new avenues for biological exploration, which is why our field is rejuvenating and why actually we need the embracing of complicated problems, again, in an unbiased approach to mark out the pathways.
Dr. DeSalvo, thank you so much for this enlightening discussion.
Thank you.
Thank you so much.
It's wonderful to be here with you.
Thank you.
Thank you.